Hey, what's up, y'all? I'm Dr. Italo Brown, and this is Med vs. Movie. Now, over the weekend, folks were literally flooding my inbox talking about this show on HBO called The Pitt. Now, I don't want to be a spoiler alert here, but I gotta make sure you all are aware that I'm going to talk about the episode in this right now. So if you haven't seen it, either turn this off and go watch it now, or just go ahead and roll on through and catch it on the back end. So this show, The Pitt, is essentially a very close-up look at the ecosystem of an emergency department in Pittsburgh. And it follows a main character who is an attending at this hospital, and all of the different interactions, like the micro interactions and macro interactions between both patients and providers, meaning nurses, medical students, residents. You also have other providers, or rather staff there. So your security guards, interaction with EMS, your social work teams and case management, like all of that is wrapped up into these episodes. And so it's really sophisticated. And for a lot of people, this is their first time ever seeing the veil kind of pulled back since the ER show of the 90s, early 2000s, if you will. I've just been kind of like, wow, I'm surprised that y'all didn't know this is how we got down. But everybody's been asking me to basically respond or react to what I see on the episode. So without further ado, I'm gonna go ahead and watch some and give you all some reactions, okay? Let's do it. All right, so starting on episode 1, boom.
42-year-old male, Sam Wallace, blunt head with agonal respiration.
Yeah, this is kind of practical.
Couldn't tube him, LMA in place.
Suicide attempt? Rescue. He's a good Samaritan. Took a spill helping a woman who fell off the track. She's right.
All right.
Okay, trauma 1, go ahead.
So my first thing is always when you have EMS come in and they transfer a patient, they usually do a more robust handoff than that. They don't just say a couple of pieces of words and then dip out. Second of all, in the transfer from the hospital stretcher, or rather from the EMS gurney to the stretcher, there was no C-spine protection. Even though he's got a collar on, you're supposed to really like transfer the person by holding that as well. But the case is super real. Someone having some type of fall. It sounds like he had a fall from a subway platform while trying to save somebody, and essentially hit his head. And so now there's like a clear injury. They've intubated this guy, likely because of airway protection or the fact that he was poorly responded, and are also concerned of potential like intracranial hemorrhage or some type of brain injury. So all of this to me seems very reasonable and likely. Just by looking at it, it doesn't look like he has a definitive airway in place. They're going to have to change that too.
A lot more blood than expected.
All right.
He's probably anticoagulated for AFib. Check his medical record, see if he's on a DOAC, standby for 4-factor PCC,
for sure.
brain bleed.
Should just know he's on the DOAC because he's bleeding. For sure.
Factors 2,
all the
7,
language is
9, and
correct.
10.
Okay, be right back.
All right, pause. In real life, nobody at the bedside while in the middle of an emergency is going to pimp you on what the blood products are. I've never seen anybody say like, yo, what is in this clotting, what clotting factors are in this cascade? Like nothing like that has ever happened. And if you're a med student on the side and someone asks you, maybe that works, but we are not in the business of trying to be pimping somebody in the middle of an actual emergency, something that will require a procedure, potentially need to go to an operating room right away. The other part that I didn't really mess with is she did this E-fast. They didn't show really any significance of the E-fast. I think that this is one of the most critical things to do. And they've already started this by going out of sequence in the survey. Usually it's airway. You want to check for breathing. I didn't see that done effectively, even though it may have happened, followed by circulation. And then you're going to go to that E-fast, and you have to shout out in the trauma bay whether the E-fast is positive or negative, because that is a definitive stopping point. If it is positive, you got to go solve that issue and go straight to the OR. So for them to be more so concerned about the clotting factors as opposed to whether or not this E-fast is positive or negative, a little bit exaggerated in my opinion. All right, let's start it again.
Didn't touch her.
Did she faint or did she trip off the platform?
Nobody knows. The other guy jumped down, pulled her off the track.
I've never, as an attending, just dipped from one room to another room without especially like being very clear about what's going on in the other room. However, if you're getting a polytrauma, or rather multiple traumas at once, there's a likelihood that you may have to serve in 2 or 3 spaces at once. So I kind of get that. This degloving injury, for those who never really heard the terminology, it refers to, let's say, an injury where your skin or soft tissue and connective tissues are kind of pulled off, almost like how a glove would from a hand. And so it's a very significant amount of force that causes these degloving injuries, and they usually have really, really bad outcomes.
Injury to the foot.
The train ran over her foot.
Got caught between the platform and the incoming train.
Ma'am?
He just holding the ultrasound, just holding it. Come on, yo.
Any English?
She's screaming, boy.
Are perfect.
As is circulation, BP 140/85.
Students.
All right, so I saw like the lower extremity. It looked real. I mean, I got pictures in my phone of actual injuries, degloving injuries that have happened from construction sites. And so those things are real. And I think that it's important for people to know, like, the way that this injury happened is highly realistic. And I think they did a good job of giving you context as to like how this could have occurred.
What might have made her faint on the platform?
Could be an arrhythmia, cardiac event,
So she needs
EKG, and a troponin.
Okay,
You
good,
got 30 people. Subway train.
Again,
Your foot with an open fracture.
I don't really agree with the shouting out of random things. Usually our surveys are very structured, and there isn't a whole lot of folks just talking for no reason. In fact, I usually will tell whoever's running the survey, if it's me, if it's a resident, to take command of the room and to verbally say like, hey, there's only going to be one voice talking. And that's so that there can be very clear communication, and the steps of what happens next can be outlined from a primary voice, and then everyone else can use the feedback, open and closed loop communication in order to drive next steps.
Dislocation.
Ooh, and I thought my heels were painful.
Dynamically stable.
Fast negative.
Ma'am, I'm Dr. Yolanda Garcia. Any pain in your chest or belly? Can we please push the morphine?
Right.
No, it could cloud
Kinda
her mental
real.
status.
I can't do an exam like this. Push the damn morphine.
We're doing a popliteal block. Numbs the lower leg, no side
All right,
effects.
Wonderful. Where's the-
There are a lot of microaggressions that they're trying to emphasize in this scene, specifically between the surgery teams and the emergency medicine teams. For context, you have to understand that emergency medicine is a surgical subspecialty. It's something that was born out of the substance of surgery, essentially covering emergency departments, and then that skill set that's required to actually run an emergency department and handle all these other things is combined with other types of specialties to create emergency medicine. And I do believe, that there are real microaggressions between certain services as well as the emergency department, especially because we're known for calling them and having them come down when they want to either be in the operating room or chilling, whatever that is. But I think that this is a little bit inaccurate, right? Like in many of our departments, we think of our surgery colleagues as team members, right? Like even though we may not be sitting together side by side, we are making decisions in tandem. We're often relying upon one another's specialties, or rather expertise, to determine how severe a situation is and what steps could come next. And so I think that the fact that there's like an adversarial relationship that's like pushed to the extreme is really exaggerated. But in real life, we're working alongside our surgery colleagues and often just kind of like collegial. So it isn't like, hey, don't do this because of this, and I don't do that. I've not seen that to that extreme. Her comment about not wanting to push morphine because it'll change the mental status is true. However, in this phase of an exam, I think that it's perfectly fine to give someone like fentanyl. I usually start 25 or 50 mics of fentanyl right away so that you can help alleviate the pain. And it most of the time doesn't really change what you want to do because of the nature of the injury. And if you're following this primary and secondary survey appropriately, giving medications for pain isn't going to really alter what you choose to do from a, not just an exam standpoint, but from a imaging study standpoint. So I think that that's kind of why I disagree.
popliteal block. Numbs the lower leg, no side effects.
Wonderful. Where's the other guy?
Next door. He's a bit worse.
Pan scanner, let me know when she stops screaming.
I agree with that. So pan scan is a term that we use when we're talking about doing a CT image, you know, of everything from head to toe. So you're doing the CT head, C-spine, probably chest, abdomen, pelvis, also doing reconstruction of the spine from the cervical, thoracic and lumbar levels. And then you're going to use that imaging to determine if there are other types of injuries that you physically cannot see or can't get a reliable exam for. So I agree, that's accurate.
The cords are very anterior.
This is pretty
that's
cool.
'cause we can't flex the neck.
The fact
Keep the
that
hockey
they
stick straight
worked
up.
in an actual intubation. So remember earlier I said that this guy didn't have a definitive airway. They were using some type of LMA or a device that is more accessible in the field to your EMS professionals. And so they had placed that LMA or King airway or whatever, and it helps in the short term to just kind of establish some airway, but it's not an actual definitive airway control. So they have to replace that with a true endotracheal tube, which is what you're seeing here. And this is pretty cool because they're, for the most part, accurate, right? Everything from except for the C-spine stuff. I think the first part, knowing that they're using, looks like a glide scope, and they're looking at the image on the side. They got probably like a Mac 3 glide scope there, or 4 maybe, because it's hyperangulated. Then they are showing that the tube has to pass through the vocal cords. Often people hear this phrase like, is it through the cords? That is our way of determining whether or not the this endotracheal tube is in the right position so that it can properly support breathing and then be used to control the airway. Now, what I disagree with here is usually when you're intubating somebody who has this type of a collar, you want someone that's doing inline C-spine protection. He already has a potential brain injury. We know he had a high mechanism fall. So you got to have somebody that's either lower than him or on the anterior or front of him, kind of creating a brace with their hands to keep his neck or his C-spine in normal or straight perfect alignment.
We can't flex the
So
neck.
that's
Keep the
kind
hockey
of
stick straight
the
up.
one thing that I don't agree with in this scene.
I'm in.
Good. Well done.
Bring me up to speed.
So she used a bougie, which is a long, flexible plastic rod that, because of its design, can easily be kind of manipulated into that small space where the vocal cords are. And then you can pass the tube on top of that. So it's essentially like a hollow tube that you're going to pass over this flexible plastic rod and easily slide it. Use it almost like a guide to push it right through the space where you can breathe better or where we can control the breathing. So that's accurate.
Intubated for agonal respirations, GCS5, probably anticoagulated. With what?
All right.
First time here, there's no medical record.
Hell no.
Call for FFP?
No, we got 4-factor PCC.
80 of mannitol to reduce brain swelling, then right up to
Hell
CT.
no. Hell no. All right.
Jesse for me.
Gosh.
Dr. Rabinovich.
All right, maybe this is just for the show, but everything after the intubation to me is just like clustered together. Like nobody's having this conversation right away after an intubation. There's no checking in to see even if the tube is in the right location. They have not. It's like so many other steps. The Italo numbers are not run that happen right after an intubation, which kind of makes me think that this was just movie magic. Her rambling off mannitol and all these other medications, it's accurate to an extent. Like they don't fully know what kind of trauma has happened, but they're suspecting that this person may have like, a herniation or something like that inside of the brain, or the brain is herniating. And so they want to give medication that reduces kind of some pressures inside the brain to give this individual the best possible chance of survival. I, again, think that it's wild that they would just start rambling off different medications and things to deliver. But I guess it's because you can only show this in a 2 minutes time frame. I'm also not just walking straight away after one of these. I think people need to go with their patients to the scanner to ensure that nothing happens. So this is just one scene. And so I can do this all day long, y'all. I promise you. But in general, I give the accuracy of this about a 7.5, right? I think that the terminology is correct. I think that they are very, very good at showing some of the necessary steps. For example, as I said, proper transfer, using ultrasounds, the intubation technique, even some of the communication. Where I think that is less accurate is the order of steps, meaning not going to a primary or a secondary survey fully, not demonstrating that. The idea of what we call pimping in emergency medicine or in medicine, where someone's asking you kind of trivial questions about medicine while you're in the process of trying to save somebody's life. That doesn't really happen like that. And then finally, all of the things that we do after a procedure, after a survey, to ensure that the patient is protected and to ensure that what we've done is correct. Like those things were kind of like glossed over and run through really rapidly. So again, 7.5. I'm gonna be a little more critical because this is my life, but at the same time, I love the fact that they give you the excitement. They give you the actual visuals. So you're not dealing with kind of like this make-believe image. It's like, no, this is what they come in looking like. Their head be bleeding on the table, right there on the pillow, on the bed or whatever. And they are literally incapacitated. And this woman can be screaming her head off. And that is all realistic. So I salute them for bringing some of this chaos and the craftiness of the specialty straight to the forefront. All right. If you want to hear more, make sure that you like, subscribe, and follow Med vs. Movie. I'm Dr. Italo Brown, signing out.